All right, today I want to talk about throughput analysis. Okay, throughput analysis. Okay, and again, the concept here falls under call it Lean Six Sigma process improvement, waste elimination, and variation limitations. You want to reduce variation, and you want to eliminate waste when you're talking about Lean Six Sigma. But in a throughput analysis in a hospital setting, the focus is not just shrinking time. The focus is finding the bottleneck. Because when you find the bottlenecks, actually pluralize, right, you can then build a plan around those bottlenecks. Typical throughput issue in a hospital is considered from admission to ICU or med surg, really just the flow I'm talking about here, to maybe diagnostics. In some cases, you might have diagnostics here, and then to discharge. Okay, so there might be a surgical component here, or a procedural center or procedure that's done, all different things that may come here. But typically a patient does not discharge from surgery except if it's outpatient. But again, big picture, right? When you're doing a throughput analysis, what you're asking yourself is, if it's as expected that the patient would be here for, say, 4.5 total days, okay, and they spend about maybe 3 of those days here, and then you're expecting 1.5 days here, then you ask yourself, how do we honestly improve that time, aka shrink that time? What is keeping that patient in this place if they stayed longer than the 4.5 expected? So if the patient's staying 6 days, how did we add 1.5? And so in a throughput analysis, you're assessing every step of the way. You might assess from admission to orders, right? So in essence, when a patient is admitted by or seen by the ED doc before the hospitalist writes orders to bring them inpatient, how long was that? Is it because they were waiting on a test? Okay, what was the issue there? Was the issue that EVS did not claim the room, right? Timely, okay? Was the issue that an EEG was not read by the neurologist? You see that? So you basically start looking through all the different areas. Was it an admission related issue? Was it a diagnostics related issue? Was it an inpatient related issue in the ICU, med surg, PCU, whatever the case may be? Was it a staffing issue that prevented blood gases from being done by the RT because the doctor needed the blood gas? All those things should be considered. Thank you.